Welcome to RUMC Vital Signs. My name is Alex Lutz. On our show, you will meet the fantastic people who make Richmond University Medical Center thrive. RUMC is an award-winning, full-service hospital located right here on Staten Island at 355 Bard Avenue. To learn more about the full array of services provided at RUMC, visit www.rumcsi.org. A stroke occurs when blood flow to the brain is blocked or there's a sudden bleeding in the brain. According to the U.S. Centers for Disease Control and Prevention, every 40 seconds, someone in the United States has a stroke. That's nearly 800,000 people, with over 600,000 being first-time stroke victims. Joining me to discuss warning signs of stroke, available treatments, and aftercare are Dr. Allan Perel, Director of the Department of Neurology, Richmond University Medical Center, and Dr. Brent Flusty, a vascular and interventional neurologist, also with Richmond University Medical Center, and with Interventional Neuro Associates. Welcome to the show.
Thank you.
Thank you for having us.
Thanks for coming on. Dr. Perel, as I mentioned, a stroke is caused by a blockage or bleeding in the brain, but why does it occur in the first place?
It's the same issue that occurs with someone who has a heart attack, and we use the term brain attack with patients with stroke. What happens is over years, because of genetics, things like diabetes, high blood pressure, high cholesterol, plaque makes the whole of the lumen of the artery narrow. And that over time closes off the artery. And that will cause lack of blood supply to a part of the brain. When that happens, if too much or too little blood goes to the brain, we get a stroke. We get a part of the brain that actually dies.
And there are different kinds of strokes, correct?
Yes, there are. It's almost it's like thinking about your plumbing system, where if a pipe gets clogged, it could do one of two things. It can close off or it could burst. If it closes off, you get what's called a cerebral infarction, or an area of dead tissue. If it bursts, we get a hemorrhage or bleeding.
And what are some of the risk factors?
As we said before, hypertension, diabetes, obesity, cigarette smoking, and actually a recent one was COVID-19. We saw more and more young people have strokes because of COVID.
And with the research from COVID, has there been any, why that was happening?
It's an inflammatory process, and we sort of inflame the blood vessels, and it causes strokes in younger people.
Wow. Just more in younger people than older people?
It happened more in younger people than older people because they mounted more of a stronger inflammatory response.
I see. And what are some of the warning signs of stroke?
Beforehand, and we use the word FAST, facial weakness, arm weakness, speech problems, and time. So the idea is getting to the doctor, getting to the hospital, not even to a physician's office, getting to an emergency room as soon as you can is really crucial with this. And
with the symptoms, is a stroke a sudden onset of symptoms? Does it build up over time?
Almost by definition, stroke means a sudden event, an acute event. But we can have some warnings. We could have warnings where if somebody would say, I woke up yesterday, my arm was numb, or I'm having problems with my speech. That could be a warning to say, let's get to the hospital, let's get to the doctor, let's get a workup, let's see what we could do to prevent the stroke.
Okay. So someone is experiencing what may be the symptoms of a stroke, they call 911. What happens when they get to the hospital?
First, EMS. EMS is very much involved in stroke. A number of places in the country are really having interventions by the emergency medical technicians. When they get to the hospital, there's a nurse in triage. In the old days, when someone had a stroke, they would be put in the back room. Let's watch them, let's see what we could do. Now, they come right to the front. They are called a stroke code. Things are being done in a very timely fashion. Blood pressure is managed, blood work is taken. People go to what's called a CAT scan machine to get a picture of the brain and see what kind of a stroke it is, and to see if we have any intervention that we could do something to make someone better. I think one of the comments and one of the numbers that come out is you lose 2 million brain cells every minute.
Wow.
It's a very large amount, and you don't get those back. Brain cells don't divide readily, so they don't come back. So once they're lost forever.
So once you determine that it is a stroke, how do you confirm, and what's the course of care, immediate course of care? First
of all, it's a clinical diagnosis. Someone comes in with an acute onset of symptoms. We get an imaging study such as a CAT scan. And if we see there's no hemorrhage, we're also doing an artery test to see if there's any narrowed or what's called a large vessel occlusion. We want to see if one of the large vessels are closed. And if they are, we're going to call someone like Dr. Flusty.
Well, that actually leads me to my next question. So why don't we start by explaining what is a mechanical thrombectomy?
Yeah, so a mechanical thrombectomy is a minimally or non-invasive procedure that uses catheters or little small tubes to track through someone's artery either in the arm or next to the groin here, and to mechanically remove a blood clot that's causing a stroke, as Dr. Perel was explaining. We do this procedure under X-ray guidance, and we're able to actually, under X-ray guidance on a screen, see where our catheter is, locate where the clot is that's causing a stroke, and remove the clot mechanically under suction.
So it sounds somewhat similar to like a cardiac catheterization.
Very similar, very similar. We use a lot of the same catheters, a lot of the same materials to perform cerebral angiography and then ultimately perform a mechanical thrombectomy.
So Dr. Perel calls you and says, we need you to come in and do this. Walk us through that process. How do you prep the patient and how do you do the procedure?
Sure, yeah. I mean, it all starts with the CAT scans and getting the story from Dr. Perel. He'll tell us what the story is, what symptoms the patient has, and then we're able to match those symptoms with the CAT scans that we can get on our phone immediately. So we'll get a CAT scan of the brain. We'll see if there's any damage that's already occurred to the brain. We'll get as he indicated, a CTA or a CAT scan of the arteries in the brain, and we'll localize the blockage. Once we see that there's a blockage, we'll activate the team in. There's nurses that come in. There's radiology techs that come in. There'll be an anesthesiologist there. The patient will be laid flat on a table that's surrounded by X-rays. Usually we do this procedure under general anesthesia, so the anesthesiologist will put the patient on a breathing machine, and then from there we'll prep the patient, clean them off, and then and drape them, and then we'll use a little small little needle to put the catheters in the arteries, and then track the arteries up to the neck and brain and localize where the clot is. And like I said, we're able to mechanically suction out the clot that's causing a stroke.
And where is the point of entry?
So we can do it in the wrist, in the radial artery. We can also do it next to the groin in the leg and the femoral artery.
Now, what are the qualifications to say that this person should have a thrombectomy? Or is it just everybody can have one? No,
so anyone with a large vessel occlusion or an occlusion in one of the main arteries or main blood vessels in the brain is a candidate for a thrombectomy. Through recent research, we're able to extend the time window that someone would qualify for a stroke. So up to 24 hours since that patient was last seen normal, we're able to perform a mechanical thrombectomy under the current guidelines. You know, we're not doing these procedures on patients with smaller strokes. It's really only a stroke that causes a severe lack of blood flow to one side of the brain or the back of the brain. And the main goal of the procedure is to get the clot out as soon as possible, to restore blood flow to that part of the brain, and in turn, the patient will have less symptoms long-term going forward and going home.
And how long does a typical thrombectomy procedure take?
So it can take as little time as 15 minutes, or it could take up to a few hours. Really depends on you know, how much clot burden there is in the brain. It depends on some anatomical factors with every specific patient. But like I said, the goal is to do this as fast as possible, and because as we said, time is brain. Brain cells are actively dying, so we need to mobilize quick. And the team comes in and we do this very quickly.
And how long is that time, I mean, to do from the time a person in the emergency room is diagnosed with a stroke, candidate for thrombectomy, that you finally get in there? What's that time frame like?
So yeah, we like to do this within an hour. We like to get the patient on the table within an hour of them hitting the door to the ED. You know, as soon as the patient gets to the ED, as Dr. Perel was saying, stroke code is activated. We're getting a neurologic exam on the patient. We're getting the CAT scans as fast as possible. And once we diagnose that there's a large vessel occlusion, we're bringing the team in. And we like to get the patient on the table within an hour, puncture the vessel within an hour, and get going.
And when you say that this is primarily for major arteries in the brain, how many arteries are in the brain? What's a major? What's a major? What's a minor artery?
Yeah, so the main artery leading up to the brain is the carotid artery in the neck. And then from there, we have a middle cerebral artery, which supplies most of the blood flow to one side of the brain. We have a middle cerebral artery on the left side of the brain and the right side of the brain. And then in the back of the brain, we have a very important blood vessel called the basilar artery. And this provides blood flow to the brain stem. So those are the main three blood vessels that we perform this procedure on. We're also doing the thrombectomy on two other blood vessels in the brain, the anterior cerebral artery and then the posterior cerebral artery.
And I guess a question for both, is there a portion or a section of the brain that is more common for strokes to occur in?
No, basically, it's blood flow.
It's blood
So
flow.
if you think about it, the carotid artery, about 80% of your blood supply goes through the front.
Okay.
About 20% goes through the back. So 80% of strokes are in the front. There are two vessels that come off of the carotid artery. One's called the middle cerebral and one's called the anterior cerebral. The anterior cerebral, which is in the front, anterior, is about 20% of blood supply. The back, the middle cerebral, is about 80% of the carotid artery supply. So there's nothing really unique about it. It's where the blood goes is where the strokes occur. So front of the brain is 80%, back of the brain about 20%, and that's why, and we know very well before someone even gets to the emergency room what they have. EMS has been trained, and they come up with scores called LAM scores, after Los Angeles motor scores, to tell us on the phone. We're pre-notified that there's someone coming in, and based on what their symptoms are, meaning if they have a speech problem and motor weakness, paralysis, we know this is a pretty large stroke if that's there. If someone comes in with a little numbness in their hands, we're still worried about it. But we know it's probably a smaller stroke. And again, we can be fooled, but we do know even before someone comes in. We didn't mention before that there is another intervention we do even before we get to thrombectomy, is we have clot busters. There's a drug called TPA, which we used to use a little bit, now we use something called TNK, which is very similar to it, tenecteplase. And what it is it's a material that within 3 to 4.5 hours out, we can give that. It will be like a roto-rooter kind of thing. He does actually more roto-rooter. We do more the Drano, using my pipes where we dissolve the clot. And that actually helps. So even if you think you're going to do a large vessel occlusion thrombectomy, doing the first part is actually advantageous.
So you can do both. You can. Okay.
Absolutely.
And the drugs you're mentioning, are they intravenous, injections? How do you administer the drugs?
They're intravenous treatments. And one other point that you made so well and we talked about is the team. You know, the pride that I have in the synchronicity of the team at RUMC is amazing. From EMS to the triage nurse to the nursing care to the radiology technician to the radiologist reading it to the neurology team being on call. And you said that I have to be involved. Yes, we're clearly involved, but when these things are so time sensitive, it's really the wonderful emergency room doctors and people in the ED that really make the difference in whether we get this done or not. There's no way that everyone could be in the hospital at all times. And that's really what makes it such a unique situation.
You said we had Dr. Rotatori, our cardiologist, on a couple episodes, and he basically echoed what you just said. From the time you call on the team, from the time the 911 call comes in to the ED to cardiac cath, it's truly, most people don't realize how many people are actually involved in that care team that they'll never see, they'll never hear about, but it's actually more than just the 2 or 3 doctors that you might actually physically interact with.
Definitely, yeah.
How effective is a thrombectomy?
Mechanical thrombectomy is very effective, and we can measure this in a couple ways. So the main goal of the procedure is to get the blood clot out as soon as possible. Studies have shown that we're doing this now from about 65 to up to 95% of the time. And we're getting the clot out successfully. So we're getting the clot out and we're restoring blood flow to that part of the brain. So the brain is able to function afterwards, and someone's able to talk again. Someone's able to move the left arm or the right arm again. The other way we can measure this is through functional independence. So all the studies that have looked at mechanical thrombectomy as a viable treatment have looked at the 90-day outcomes in these patients coming in with a large vessel occlusion from an acute ischemic stroke. The studies have shown that through a mechanical thrombectomy, 46% of these patients are becoming functionally independent again, as opposed to just 26% who get treatment with medical management alone. So the main goal, 2 main goals, get the clot out as soon as possible, and make sure, and the sooner we do that, the better chance someone is able to go home, go to the grocery store again, drive their car again, visit with family again. So those are the two main goals, and that's how we measure the effectiveness of a thrombectomy.
And how many stroke patients a year are we treating at RUMC?
About 300 patients.
300.
And that includes from minor episodes. Some people use the term TIA, which is a mini stroke. They use the term mini stroke, but really what it is a temporary or transient loss of oxygen or blood supply to a part of the brain. So there's something that blocked it off for a moment or two or a minute or two, usually less than an hour, and then the blood flow is restored without any damage. So it goes anywhere from there to a completed stroke, which are people who have had a stroke. So many times we're seeing patients coming to the emergency room too late. The education and what we're trying to do even here is just the idea that if you have any neurological symptom, you have to come into the hospital. The same way cardiology, I always think about neurology being 20 years ahead, 20 years behind rather, and cardiology being 20 years ahead. Where if you had with Thanksgiving dinner and you had indigestion, you say, I'm not going to go to the hospital. Now we've taught people that if you have chest pain, even right after you eat, get to the hospital. And we're trying in neurology to have the people of Staten Island, people all over, get to their healthcare provider, get to the emergency room as soon as possible because there are so many treatments available.
And do you think it's just lack of education? Do you think it's fear about going to the hospital in general?
Too many people say, I'm going to go to sleep and I'll feel better when I wake
in the
up.
morning. You know, it's almost like the seatbelt mentality. Years ago, we didn't wear seatbelts, and then they started the campaign, and now we're wearing seatbelts. The idea of not wearing a seatbelt. So if we have 300 stroke patients a year roughly around RUMC, how many are receiving or eligible or have a thrombectomy performed?
Yeah, so we've done about 20 thrombectomies this year.
This year alone?
From the stroke program building, I think that number is only going to go up. But 20 patients we've taken care of in the IR suite who have undergone mechanical thrombectomy for a stroke.
And are you seeing an increase in strokes because of anything in particular, or is it just people are becoming more self-aware of the symptoms and calling 911?
I think awareness is a big thing. I think people are becoming more aware. I think education is a big part of that. Dr. Perel mentioned the FAST or B-FAST mnemonic that is becoming very popular, I know, in New York City. So the education is increasing. More and more people are aware of what a stroke is. More and more people are aware of the signs and symptoms of a stroke. And they realize that this is a timely and deathly matter that needs to be taken serious, so they're getting to the hospital sooner and more often.
So between the thrombectomy, the drugs that you mentioned, after all of this is done and the person how do you gauge recovery? How do you monitor them? Do you look for immediate signs, or is it a waiting period?
Yeah, so sometimes patients immediately get better right after a thrombectomy. They're taken off general anesthesia and they're able to talk again. They're able to move their arms and legs again. Those are the great cases that it's truly why we do this. For everyone who undergoes a thrombectomy, they're admitted to the intensive care unit at RUMC. We monitor their neurologic status, so their neuro exam every hour. And then they undergo a series of tests to figure out why this stroke happened. And as they're undergoing these tests, physical therapists are seeing them, occupational therapists are seeing them, speech therapists are seeing them. And we're able to see how well they're able to move their arms and legs. Are they able to swallow? Are they able to speak? And based off that, we're able to see where they're going to go after the hospitalization. So are they going to an acute rehab facility where they can handle 3 hours of physical therapy and occupational therapy a day? Are they going to a subacute rehab facility, or are they going home, which is the best case scenario?
And how long has this procedure been around, thrombectomies, roughly?
It's been around, since the late 90s. In 2015, it was a big year for the research involved in mechanical thrombectomy. So after that, it's changed the guidelines of stroke treatment. So since 2015, it's really taken off in the right direction.
So you were practicing before thrombectomy came along?
Yes. It is miraculous.
Is it?
And I think, when we talk about thrombectomies, the technology has changed. That's what's made it so much more, that's why it's made it so much more safe and effective. There's little umbrellas, there's ways to catch things so that it doesn't cause any more problems. And you think, if you knock off a clot, you think it should still be breaking off, but we're trying to capture it. So the technology has gotten really so much better that patients are doing so much better. And there's nothing more miraculous. And when I have medical students, residents, nurses come up to the intensive care unit to see someone who's had a thrombectomy, or even someone who's had some of those clot busters we talked about before. And when they see them in the hall, tears come to their eyes to see how much better they're talking to them, they're smiling, people looking much, much better. Obviously, it doesn't happen in everyone, but it really is miraculous when it does. And to have this available is really so important.
So without breaking privacy, is there a case or two that stands out that you have both, that stands out to both of you in your careers?
I think, we had a recent thrombectomy that went very well. An older patient in her 80s came in with a occlusion of her left middle cerebral artery. And on the left side, that's our language center. So patients with a left MCA stroke are unable to speak. They're unable to interact with their families. And they also come in with weakness on the right side. So this is an elderly woman with grandchildren. She wasn't able to interact with her children, her grandchildren, and we were able to give the clot-busting medication in the ED. We brought her up for a thrombectomy. I think I got the clot out in less than 15 minutes, and then the patient went in the ICU, and she's completely back to normal. And she's going to have Thanksgiving dinner at home with her family.
That's great.
Those are like I said before, those are the good cases, and those are the cases that make you realize that, we're doing good work here.
All right. How about you, Dr. Perel?
It's a very similar case. I mean, someone on one of the holidays, I think it was Thanksgiving, came in the morning while she was preparing, and she couldn't talk, and her arm was weak. We did the same things. We gave the clot buster, the thrombectomy, and then the next morning I came in to do rounds, and I see this lovely dressed person, a woman in bed, and I said, "Where is?" And she said, I'm this person. And I said, "Wow, you look great." And a big smile came up on her face, and we hugged, and she was so happy. And she was actually one of our first cases after we got the ability to do thrombectomies.
Oh, wow.
And it made the entire ICU staff was clapping. People from the emergency room came up, and they were hugging. It was really a very
That's got to be the best feeling.
Absolutely.
It's fantastic.
That's
it's really good.
That's why we do this.
Right. But you also, there's the other side of it. I mean, you guys are dealing with something that is an emergency, especially when you're going. How do you, for lack of a better way to say, how do you get your game face on?
Yeah, so I mean, for me, it's all about trusting the process. We went through everything that happens, all from the EMTs in the field to the ED. Everyone has a job to do, and as long as you follow that process and get the patient up to the lab as soon as possible, talk to the family about the procedure before, which I think it's very important to lay out what the patient is facing, not only now, but in the future, and truly just focusing on the procedure. Thinking about what you're going to do in the case before, and then, just making sure everyone's doing their job and doing it safely.
And I know RUMC just recently started a new stroke support group. Dr. Perel, you want to tell us a little bit about it?
Sure, it's a wonderful group. It actually met just over the last few days again. And a number of people come out, and everyone's a little hesitant in the very beginning. But we had a wonderful speaker about someone who had a hemorrhage and a relative with this. And she formed actually a national organization to try to support people. We even have a support group for people who can't speak, what's called aphasia. It's just a word for people who have language problems. And if you think about it, how do people with language problems come to a place and talk to each other? And they do. And people get by, they're able to do it, and people feel very uninhibited. They talk about things. It takes a few minutes. And the idea that they see other people who have similar problems is just so important. And we've got a nurse there, we've got a social worker there, we've got a whole coordinated group, trying to make people feel comfortable. And I think the support groups are huge for any disorder in the world. Knowing that there are people out there that care about you, who have similar problems, is just what's so important. But this group is getting together and it has a life of its own. Who's the leader of the group, who calls up the group, how many people come, what time they come, what do they want to have, what kind of snacks. So it forms like a whole nice alliance, and it really is wonderful to see people who've had a major medical problem do well, and even if they're not doing as well, just get the support of others to get through some very harrowing times.
I mean, then, RUMC has a number of support groups, and sometimes there's a hesitancy in joining a support group. People kind of look at it as just it's another form of treatment, and I don't want to do that. How do you convince people to come to a support group?
You almost have to beg them. You have to say that, especially, I think the caregiver or the significant other especially when they need it as much as the patient does. The person who's ill understands that they're ill and they're upset about it, but the person taking care of them always is the issue and needs to see other people who are caring. And they're able to share ideas. There's so many programs out there, whether it's lunch at the YMCA or JCC on Staten Island, whether it's just going for which physical therapists they like or what programs they like. That really helps them dramatically. So again, it's having both the person and sometimes convincing the care person to come in with them really does turn the key for them to come over.
And if someone watching this episode wants to join the support group or learn more about it, how do they do that?
They call Richmond University Medical Center. And my stroke coordinator's phone number we could put up online and however we're going to do it. And please call us up. We are looking for people. We want people. We've got more room in the big auditorium. It's more of a social hall. It's not really an auditorium. So again, everybody feels very close to each other, and I think that would be very rewarding for them and anybody else in the family or friend who wants to come in with them.
How many people were in the initial meeting of the group?
There were about 60 or 70.
And different ages,
Yes.
and suffered from different strokes, different situations.
And in a sense, that's why I think Dr. Flusty and myself went into neurology. We see people from early age to very advanced age, and that's a nice part of what we do. And we try to take care of people across the whole spectrum of ages. So yes, younger people, older people, and many people. And the best part is some people, you look in the room, you don't know whether they or their caregiver, which one of them has the stroke.
Wow.
They've done so well, they're coming in, and you really couldn't tell the difference.
Wow. So it sounds like there's been a lot of advancements since you got into the field. You're relatively young. Well, it sounds like from immediate care straight through to aftercare, there is just a full support at Richmond University Medical Center, thanks to everything that you and the team are doing. So really, thank you. It sounds like all the bases are covered. Thank you for all that you do for our community and for all that you continue to do for our patients. Of course. Richmond University Medical Center has cared for Staten Island and the New York City metropolitan area for nearly 120 years. You can help ensure that care continues by making a financial contribution to the hospital. Donations can be made in your name, the name of a loved one, or to honor a special nurse or doctor at Richmond University Medical Center. To donate, visit our website at rumcsi.org and click on the Donate button located at the top of the homepage, or you can call 718-818-2106. That just about does it for this episode of RUMC Vital Signs. Thanks for joining us. I'm Alex Lutz.